cautious. Why do we need to be cautious about him? He's on so many medications. Number one,
He's not sleeping well.
he's not sleeping well. He's been seeing other. He has seen other physio. Okay, no progress. And just by looking at the way he moved, even just by lying there on the stomach, he was not comfortable. So his condition, he is not severe, but you just need to be really careful. Okay. So the reason being was so can't get comfortable in Chrome. What else? So sleep poorly. What else? Failed treatment, failed previous treatment.
Medication.
Many medication. Yeah. So if we are not careful, his condition can be very easily aggravated. Okay, and then is the condition irritable? Explain why. Okay. Yes, the patient claims that he finds bending backwards and lying on his stomach difficult and feels onset of symptoms going down. So like that there are a number of functional activities that are difficult to perform. Okay. Now irritability. What are the criteria for irritability?
Severity.
Okay. Severity. Duration. And easing factor. Okay. Now, so you want to say, is he severe? I don't know. You say yes, I say no. Yeah. That's pretty subjective. So you can ask him about the VAS. Which I don't normally ask. Anyway, duration. And how easy, so easing and aggravating, how easy is it to be aggravated, or the duration? So we didn't really ask the duration, isn't it? Yeah, aggravation, easing factor, how easy can it be aggravated? Actually it looks okay. Yeah, you can still walk in here. So I tell you what, a truly irritable patient. No control. And then as soon as you walk outside and greet the patient, he stood up with difficulty. Yeah. And then he has to furniture walk into the room. That's truly irritable. Okay, truly irritable. He is not really irritable. So clinically, you don't really see so many irritable. No. So moderate severity. Can still walk independently. Can still walk and move independently, so he's not really irritable. Why do we ask irritability? Because we want to say, okay, we want to make a judgment very quickly, want to make a decision very quickly. Are we going to assess the patient thoroughly? Okay, which you did. Okay, so he is not irritable. Otherwise, we wouldn't have gone through this pathway. We wouldn't have gone through the assessment. Okay, if he's really irritable, then we don't. Yeah, we want him. We want to lie him down. We want him to be in the comfortable position, and we wanted to relieve his pain. Okay, so minimize our assessment. So irritability help us to determine which way we go. Okay. Are there any precaution contraindication? Okay, C4. Yeah, we don't really know if that's healed. I think that's healed. Okay, but just put this on the back of our mind. Best if we can get a X-ray. So failed past treatment. Okay, precaution. How is the severity, irritability, and nature of condition going to affect the physical examination treatment? Always stress to stop immediately as soon as they feel tightness. So this is just the way that we assess here. It's not really answering the question. How is the severity, irritability, or the nature of condition going to affect your physical examination? So, careful positioning. Just be careful with that. We can do full assessment on him. Just gotta be really careful, not to aggravate. Okay, and also here use R1, so that we don't aggravate his condition. So this is the type. He's a strength and conditioning coach. He is used to pain. He's very used to pain. He would like to push into pain.
Yeah.
He may think pain is good. Okay, and it's important that we tell him to stop immediately when he feel any discomfort. So I think that's a good answer. What subjective finding indicate physical finding? What subjective finding indicate likely physical finding? So difficulty with extension movement. So from which part does that give you the clue? So from his subjective examination, you are now predicting his physical finding.
When he is standing up, walking, running.
Standing, walking, running. How is he sitting? Did he say
Prolonged
he's trouble
sitting.
prolonged sitting?
Yeah.
Okay. So likely physical finding. Limited with twisting movement. Twisting, maybe he said twisting. Okay. Subjective is what other factor need to be examined as reason why the structure has become symptomatic? Posture, work, job, tasks. Current exercise and gym. Yep, work. What is clinical diagnosis? CO5 instability. So remember, this up to this part is before the objective.
Yeah.
So if you
Okay.
can answer that, that's pretty good. Okay, to complete after the objective. Were your hypotheses supported or neglected? So here is what is your hypothesis? I think this is probably a better question. What is your hypothesis? Support in subjective, the patient had stated that he had been working on his upper body in particular. So that's a very powerful one, and that improved the rotation as well. That improved Prohn's SLR and also improved the thoracic rotation. And he subjectively he actually felt better, and you can see his face. His face actually becomes more relaxed. The L5 it is an L5 problem. Is there anything about your physical exam that indicate caution? Long said, your physical exam, lumbar extension. Lumbar extension is very early onset. Very early onset. Yeah. See, when he tried to get into prone, because he had a little bit of extension when he tried to get into prone, and he wasn't he wasn't comfortable. And then I remember you offered to put a pillow under his stomach, and he said, don't worry about it. Okay. I think it's important, even though he refused it, every now and then you ask, how do you feel lying down on your stomach? Do you feel any pain lying on the stomach?
Yeah.
If he has pain just by lying down, then your physical examination is not going to be accurate, because you have already passed P1. Okay, and we always say we want to stay short of R1, and R1 is always before P1. So you get to R1 first, and then you get P1. Okay, so if the patient is already in pain, lying down on the stomach, he's already in P1. That means he's already past R1. Okay, then his body will be guarded. You have guarding. So any of your assessment will not be accurate.
Yeah.
And so it's important that you make sure that he is comfortable.
Okay.
Feel under the stomach. Under the stomach. Or lungs. What are the main problem? Okay, so these are the objective findings. You probably say objective findings other than the range of motion. Remember, we also have asterisks in the TOD section. Yeah, so L5, we think we have calf, we have infraspinalis, whatever, it's got an asterisk sign on it. Okay, how will you manage this patient? You do L5, transfer glide, that's a TDT. Avoid extension, brace, keep brace. So everything here, these are all the asterisk signs. We want to see as many of them improve. Okay. The more they improve, the better is the treatment. Indicate your treatment progression over time. So I think they're asking you, so L5 is helpful, so how do you progress the L5 treatment over time? Okay, so let me ask you. So L5 is L5 help him from the TTT. Yeah. So what's going to be your first choice of treatment in the next session?
Transverse glide.
Okay. Maybe prone. Okay. Maybe with pillow on the stomach.
Yeah.
Okay. And then you progress. So you treat him with that, and he got better. Then what's the next progression?
With movement?
That's maybe a little bit too fast. Let's just progress the same treatment.
Transverse glide.
Increase the grade.
It's always grade 4. You can increase grade. We don't really increase grade. We increase the position. So how do we
without the pillow?
Yeah. with no below. And then that helped. What's next?
With movement.
In sitting,
Mm-hmm. Okay. In sitting
or standing,
or standing. Okay. What else? Let's just go back to this one again. What can you do?
Prone with movement.
With
move like extension elbow
in extend. Well, that's in extension.
from
In some lumbar extension. Okay.
Mm.
Maybe in 10 degrees lumbar extension, and then you can increase the lumbar extension more and more. Okay. Or you can do you can put the bed head up, so he's in a little bit of lumbar extension, and then you can do L5 transverse glide. Okay.
Mm.
You can do in prone with active extension. Okay, shoulder pen. Okay, L5 is in sitting and standing, and then how can you progress that?
with
With
movement.
movement.
With what movement?
Lumbar extension.
With rotation. Could you try
Mm-hmm. And then
And then pre-position.
and you can do
No,
combined movement.
quadrant?
Yeah. There are a lot of things you can go on and go on and on and on. Okay, so what goals do you expect to achieve? So this is very hard to quantify, isn't it? So what is
That's
a
more
good
subjective.
what is a good goal?
Objective vision.
Goal has to be smart. Okay,
Mm.
what's a smart goal? Specific,
Measurable.
measurable, achievable, realistic, and time based. Okay, so how can we write a good goal for this patient? So that by the end of the 6th session, so by the end of 6 sessions,
To be able to
yeah, the patient can
sleep 6 hours without any disruption in 3 weeks' time.
Mm-hmm. Yeah, that's 6 session. Is that specific? Very, do we achieve or not? It's not specific, measurable. Yeah, 6 hours. Do we get 6 hours? Achievable. I think it's achievable. Realistic, yes. Time based. That's a very good goal. Mm-hmm.
Yep.
Okay. What other goals? Can we do that? We can do the same thing. Oh,
So like
okay. So he has achieved that. He has achieved this. Okay, he comes in. He said, this is the last session. He said, yeah, I can sleep well. And then do you say, okay, good, then see you later? Or what can you do? We set a higher goal. We can set a new goal for him. What does he
So-
like?
Play sport.
He wants to,
Gym.
yeah, he wants to be able to do gym without worrying about his back. Okay, so you know, really ask him what does he want to achieve in the gym. Okay, what are some of the activities that he is afraid of doing at the moment, and what does he really want to achieve? Set a new goal. Okay, so you set a new goal. Okay, once achieved, once the old goal is achieved. So we basically wanted to keep the client. You wanted to take a, you know, wanted to help the client to achieve more in life. Mhm. And you don't, unlike hospital, you discharge the patient. In a private clinic, you wanted to take the patient through a journey and fulfill his potential. You want to help him achieve more. Okay, so you always set a new goal. You need to listen. What does he want? What does he want? Okay. If the client says, really, look, I'm very satisfied with the way I am now. Okay, then I think the new goal would be maintain your condition. Maintain your condition. Okay. It becomes more like a dental checkup. Okay, by so just come in for a checkup every couple of weeks or every couple of months. Okay. Would you expect the patient to have residual sign and symptom at the end of the course of treatment? Yes. I think he will improve a lot. You know, if L5 is the main cause of his problem, he will still have some residual signs and symptoms, and that's why we need to continue and help him progress. Okay. Look, 6 sessions is a very humble. It's really a very humble and minimal course of in terms of number of sessions. In your other placement, how many sessions usually do they talk in the, do you write down in the plan?
In my last placement.
Mm.
So my last placement, there's no set sessions.
Yeah,
so
yeah.
some page depends on how.
Yeah, how many? You see, normally, I remember when I was a student, maybe we said 12 sessions, 18 sessions. How many treatments will be required? But I think 6 sessions as a block is is good. So 6 sessions we can see if he respond to the treatment. Usually, if he doesn't respond to treatment, after 3 sessions, we often don't continue seeing the patient after about 3 sessions. If the patient only showed very minimal improvement after 6 sessions, it's really not worthwhile to continue seeing physio. But if the patient demonstrates good improvement, like 50% improvement after 6 sessions, then I think there's a place for continuing session after that. Okay. Pause. Okay, Gary, have you emailed me?
刚刚有 email。 这个学说。
是这个吗？
这个。
Okay, so structure underline the area, 4 or 5, structure which can refer to the area. Good. To be honest, anything
Can be.
can refer pen to that area. These are just the more common ones. Okay, and
In fact, this I only target about the lower back,
mhm.
and I'm not really sure
Yeah.
for the shoulder.
Okay. It needs to be examined today in the whole body. A neurological examination be required. Okay, it's not really necessary. Is the condition severe? No.
It's a bit hard for me to answer these questions because we
Yeah.
don't really ask for pain.
No, you can visualize it.
Yeah.
You can tell from the patient's facial expression,
Yeah.
body movement. There are a lot of cues. You don't have to ask the patient for to give you a number. You can visualize. So I think that's for him. He's not
Not so.
severe.
Yeah.
No, because the 3 factors. Severity is low.
No.
Duration, don't think is a problem. Easing and aggravating factors. It's probably he can at least sit down for 30 minutes.
Yeah.
So it's not very irritable. Can be eased very quickly by extension. Yeah. Any precaution? Diabetes. Yeah, you asked asthma already.
Mm.
I think obesity can often be another one. So from my experience, people who are obese usually harder to manage because that predispose them to like diabetes, so they slow healing, they heal slowly. Osteoarthritis, wear and tear. Okay. So people who are obese harder.
Yeah.
Yeah. It is not low. Since it is low, I think.
Oh, it's low. Yeah. That's a typing error. Yeah.
But patient has direction preference to lumbar extension. Are you sure he